fantastic live program. Over to you, Vijay.
Thank you, Hitesh. It's a pleasure again and honor to come back to give this talk. So as suggested and asked by Hitesh, I'm going to talk about shoulder arthroscopy step by step and take you through what is required if you're going to start your own setting. No conflict of interest related to the talk. If we look at the history of arthroscopy, it was started nearly 100 years ago by Takagaki in Japan, who started, as with most things, with the knee arthroscopy. And then in 1912, there is some suggestion that he perhaps in one of the Nordic countries, the first arthroscopy, but the historical credence goes to Takagaki for doing that. And it's not until 1950s then we started to look at more about interventional arthroscopy to do the procedures. However, the shoulder arthroscopy was first started again by another Japanese surgeon, Berman, in 1931. And in 1979, Conti is supposed to have done first surgery for arthroscopy in the frozen shoulder. And then Watanabe in 1979 did the define the portals and other instrumentation for shoulder arthroscopy. And there's lots of courses actually run all over Europe and the world on Watanabe's name. He also describes the osteochondral fractures for loose bodies. Now, if we look at shoulder arthroscopy, the common indications for surgery are these four. Decompression plus minus an ACJ excision, rotator cuff repair, as well as dealing with biceps, so either a tenodesis or a tenotomy maybe is done with that. Arthroscopic stabilization and an arthroscopic capsular release for a frozen shoulder. There are other procedures as well along with that, loose body removal, certainly for synovial chondromatosis, chondroplasty in early OA shoulder arthritis in the younger age group patients, synovectomy, though done less commonly nowadays, but for inflammatory arthropathy, or for debridement in aseptic arthritis, and the indications keep on increasing. People have now started doing arthroscopic lateral jet procedures, the bony stabilization as well. First of all, we need to start at positioning the patient. So there's two well-defined techniques, the beach chair and the lateral position. And I always joke saying that, the correct position is the lateral position, or which is what I prefer to do. But world over, the shoulder surgeons are still divided. And it's interesting that certainly in the European side, more and more people, certainly in the UK, more people are now doing beach chair. But if you speak to surgeons in the US, I think still larger number do it in lateral. And certainly in India, the lateral is more commonly used position, mainly because of the cost involved with the beach chair positioner. So what's in the beach chair, as the name suggests, it's the patient is semi-sitting, is fairly sat up. So this is not your typical beach chair where somebody may have done a fracture fixation or indeed open reduction for some things. But this requires almost 70, 80 degrees angle sitting up. It does require a special positioner, and there is always a sterile disposable bit commonly used, which increases the cost. The cost of the positioner itself is significant, and hence I said in India I see more of lateral position. There's advantage that it's easier to do an open procedure if you do it in beach chair. There's issues with the anesthetic, and some people say that stabilization is more tricky, and certainly the ones where I've done it, it is more difficult than doing it's in lateral position. So that's what the setup looks like. And as you can see, this is quite a fairly sat up upright position. In the lateral position, as the name said, there's no special positioner required, although I do use an arm holder, but it can be done using any IV drip stand to hold it in place. It does need a traction device. I find that it provides easy access to the shoulder all around. And now my anaesthetists usually don't put the patient to a tube. Yes, there is a learning curve with as with anything, but so you can have a slightly more complicated stand like this, or a simple traction device like this. With practice, the difficult open cuff procedures become easy and straightforward once you're used to it. That's what it looks like. Now, just to briefly summarize the advantages and the disadvantages, I think as a surgeon, it's more what you train with and what you feel comfortable with it. And hence, most of us would tend to stick to one position. There are a very few surgeons who would swap positions based on the type of procedure they do. I mean, I do beacher position for all my arthroplasties, obviously, but I do my arthroscopy procedures in the lateral position. The advantages of the beach chair versus the lateral is listed here. Now, most of my anaesthetists in my situation, in my patients, don't even intubate the patient. They're usually on a LMA or a mask, and that generally works. I know in India a lot is done under just a reasonable block, but that has its own disadvantages of doing that. So just to show you the lateral position, how I do it, just a short video demonstrating. So this patient is left lateral for a right shoulder arthroscopy with a traction device that is held in place, but you could use an IV stand. This allows good distraction. So here what you can see is, sorry, I'm now. So what the advantage of this is, you can actually distract the shoulder in a desired position. So as you can see here, we'll stop it there. So in this position, what you can do is, if you increase the traction along here, you can distract this subacromial space. And by asking your assistant to lift under the armpit, you can open up the glenohumeral joint space again. Sorry. And that's what it looks like. You can increase the abduction amount, and it needs about 8 to 10 pounds of weight to hold it in place. I'm now going to show you positioning in the beach chair for shoulder arthroscopy. So this requires a special device to hold the arm. The arm can be wrapped around. There are a variety of this devices available on the market, but it's not something that you can make do provision from theatre setup, which is possible in the lateral position. The advantage is that the arm is free and sterile wrapped, so you can put in any degree of movement, abduction, rotation as required. The portal marking is similar, so feel for the anterior edge of the acromion and the posterior edge, and then draw a line along the lateral side. Identify the ACJ, which is prominent, mark the coracoid process, and then looking for the lateral portal is anterior 1/3, posterior 2/3. A junction about 2 centimeters distal to the edge of the acromion, and the posterior portal is about 2 centimeters medial and posterior to the posterior edge of the acromion, and the anterior portal is generally in line of the anterior of the acromion, slightly distal to. So the setup is usually a general anesthetic with a nerve block, and I do say to the anesthetist to keep the blood pressure around 100 unless the patient is high risk with high blood pressure. Because often I easily point it out to the anesthetist that the blood pressure has gone up because the field becomes bloody. You need a camera stack, a fluid management system, as well as specialized instruments, which we'll briefly touch in all of them. So the standard instrument equipment includes a camera, a light source, a monitor connected to it, a recorder, fluid management pump, some shavers, radio frequency probes make life very much easy, graspers or specialized instruments, and then obviously any procedure-based instruments that will be required will be dependent on the procedure you're doing, and I'm not going to go into details of that. So this is what a standard stack looks like. You have a big monitor. Sometimes these days you have an additional monitor for your assistant to see, or you could take it with you connected to a Wi-Fi and sit in your office while your assistant is doing the procedure. That's the camera, that's the shaver, that's the pump, that's the radio frequency probe device, and that's the printer, all attached in one. Now, for the fluid management, I think this is vitally important, and I think this is where a lot of surgeons struggle right at the beginning to maintain the balance of keeping enough fluid within the shoulder joint that it's not going all over, and to balancing it against that, not putting too much fluid that the shoulder gets swollen. So any surgery that starts to last over an hour, hour and a half, the fluid does tend to get absorbed into the soft tissue and the shoulder can become swollen. It's a delicate balance between the blood pressure and the fluid pressure, because that will decide. And again, hence, I like the blood pressure to be around 100. So with your pump pressure about 60, 50 to 60, it will work well. And it's important to keep altering the fluid pressure. And if there's some oozing, there's no harm in putting the pressure up for a short period of time. So the flow is the movement of fluid through a space. Now, the flow of the fluid rate is the amount of fluid that passes at a given point over a given time. And this is proportional if you're using cannulas. So it's directly proportional to the diameter of the cannula that you use, and inversely proportional to the length of the, and also proportional to the pressure that the fluid is in. But remember, against this is that the volume and the force will decide how much the shoulder gets swollen. So what you need is to reduce flow resistance, which requires a high flow cannula. And this is both for the arthroscopic cannula and any additional fluid cannula that may be used. It's very common to use an additional fluid flow cannula apart from your arthroscope, unlike the knee arthroscopy, because we do not have the luxury of having a tourniquet whilst doing a shoulder arthroscopy. And the last line is vital, that increasing the pressure will only temporarily increase the flow, and the shoulder will adjust to the new pressure. Now, I have used gravity flow, and people use the gravity flow as well. The disadvantage with this is that the pressure is not constant, and as the volume within the fluid bag goes down, so does the pressure go down. So that's why it's not a great device. But yes, I have done it without the use of a pump when I used to operate with my friends in India. But you can supplement it by wrapping a blood pressure cuff or a tourniquet around the fluid bag to keep it under some pressure. What it is suggested is that it's proportional to the height of the bag where it is left, and 1 foot of water is about 22 millimeters of mercury, but this needs to be 1 feet is not from the ground, but it's from the level of the shoulder. So if you've got to go to 60 millimeters, you're looking at 3 foot above the shoulder, which may cause problems how to put it up. Now, there are a variety of different pumps that are available in the market, and I would go by whichever one you're familiar with. They are all similar, and I'm sure the company reps will tell you that one is better than the other. Now, with the fluid, again, continuing, we use high flow tubing and cannula, vital to check that there is no kinks in the tubes. And I think this is quite important, especially when you start early, that you should avoid making too many punctures into the joint space, because although you may feel it's only that tiny puncture is enough for the fluid to seep out and cause swelling. And always start with a lower desired set pressure. So on my start, it's set at 50. And then in vast majority, probably in about 3/4 of them, I don't need to fiddle with it. With the current pump systems that are available, you can increase the pressure for a set time. So most of them will have, we can set the pressure up for about 60 to 120 seconds, and then it goes back to the normal that you have got. I generally don't leave the suction on all the time, because it reduces the space and it makes it more bleed as it's sucking against, especially if the suction is connected direct, or the outflow is connected to a powerful suction. When you put a cannula for fluid, it's important to check that the cannula is within the joint space and not in the soft tissues. These are different varieties of cannulas that are available of different diameter. The most common that I use is this yellow cannula, which is 8.25 millimeters, and this orange cannula, which is 5.75. And I only use if I have to pass any sutures or other instruments through it. Other things that are vital are a variety of suture shuttling devices, like the lasso, suture grasping devices, and various burrs and shavers that are pretty much standard part of any kit for a shoulder arthroscopy. Now, talking about portals, so whichever position you are in, lateral or beachhead, the portals are pretty standard. The first portal that you make is a standard posterior portal, which is 2 centimeters inferior and medial to the posterior tip of acromion. This is just a rough guideline, and you'll always feel a soft spot, especially if the arm is in traction. I always prefer to infiltrate the joint with some saline and use a number 11 blade. I use a blunt trocar and a sheath, keeping horizontal to the floor. And when I position the patient in lateral, I lean them back about 20 degrees so that neutralizes the version of the glenoid. The anti-version of glenoid is neutralized, and you go horizontal to the floor. Generally, there is a give way. The key here is not to use excessive force, as you could end up in the back of the humeral head. That's what I mean by pushing onto the edge. And you can walk with the blunt tip onto the glenoid when you're starting. And then once you feel the dip, then you can push it in and aim for the coracoid. And again, this is where the lateral position comes in quite handy, because the arm is in traction, so the glenohumeral joint is slightly distended. So I'm going to show you a short video on the patient in lateral position. So that's the posterior edge of the acromion. I've marked the acromion, which gives an idea. And I do this in every case. This is not just for a demonstration. The AC joint is marked, palpating the two things. One is the little gap that we in the V between the acromion, between the clavicle and the scapular spine, as well as feel the knobbly bit on top of the AC joint itself. Then you go 2 centimeters medial and posterior to find your posterior portal. That's where you start first. And then I generally find 1.5 centimeters below the acromion, roughly, and you can make a portal to get into the subacromial space along any of these lines. There are some common portals here. So this is the port of Wilmington, which is good for doing your cuff repairs. This is the lateral portal, which is a working horse portal. So for all your subacromial primary works, your bursectomy, your acromioplasty, this is the portal that is used. And you can see here I've marked the coracoid process, and this is the CA ligament. And the anterior portal is somewhere in line with the edge of the acromion there. The only difference would be if I have to do an ACJ excision, then I try and put my anterior portal in line with the ACJ, as it makes life so much easier when you come to excise the lateral end of the clavicle. So that's just a pictorial view of what I have just described to you. Now, there's two techniques of doing the portal placement. One is the outside in, and I generally use this unless I'm doing a stabilization, where occasionally I might do an inside out technique. I use a spinal needle to check the trajectory of my instrument, and I always do that. Even now, it just makes it less likely that you're going to end up making a wrong portal. Portal should be as close to 90 degrees as possible to facilitate visualization and make the smallest incision required to pass the instruments. Remember, you can always make it bigger, but you can't make it smaller. If you're using any suture and devices, then always use a cannula. Otherwise, the sutures can get entangled in the soft tissue. And reduce the repositioning of the cannula to avoid seeping. And if you have a cannula, make sure it is in the desired place. So again, this is a picture from one of the books showing all the portals that can be used. The number 6 is the Nivyasa portal, which comes in handy if you've got to do an AC joint excision in a big patient and you can't access it. Or sometimes if I do a slat repair, then I use a percutaneous Nivyasa portal. The idea is to be able to see most of the areas of the shoulder, and as with most of the joints, you can put portals as necessary. These are the common ones. The anterior and the anterior superior ones are the ones for the stabilization. So Bijayendra technique is the inside out, and the outside in is where you push the a probe or a rod through the sheath to the desired position where it comes out. So the anterior mid-glenoid portal is used for stabilization, and this becomes the working portal for any anterior stabilization. And the anterior superior one is the common one used for doing any probing of the glenohumeral joint, and also works as an accessory portal for stabilization work. Now, I've described this already for the subacromial space portal, the lateral portal. Junction of the anterior 1/3 and the posterior 2/3 is what we require, and is used for decompression and cuff repair. Instrumentation-wise, what we need is a probe, cannula, switching stick. With this thermocoagulation, drills, anchors, graspers, and suture shuttles. So that all generally would come with any procedure that you are about to do, and is often company dependent what you do. So this is just a short video on looking at the normal glenohumeral joint. So I'm posterior viewing portal. That's the humeral head, that's the glenoid, that's the anterior labrum. This is quite an old video of mine. A patient, I think, had a slap tear. And this is just probing the labrum. And this is the bare spot that is often described in the glenoid, which allows you to discern how much anterior wear a patient has in the instability type of group of patients. This is looking at the undersurface of the cuff and the top of the biceps insertion, looking at labral attachment at the top. So this is probing the superior part of the labrum, looking for any slap lesion. You can see this is quite well attached. That's the long head of biceps, which looks a bit inflamed, but the attachment itself looks pretty good. And then once you've done that, you can look at the superior surface of the cuff, the undersurface of the cuff. That's probing the labrum. And this is what the undersurface of the cuff looks like. Now, this is in the subacromial space, and this is what the Bijayendra technique is, wherein the needle is put in the subacromial space. This is a normal subacromial bursa. That's the acromion. This is the cuff and the bursa. You can see this is nice, smooth, glistening in between the bursal surface. And there is no damage to the subacromial area. You can see how smooth the bursa is. This is contrasting to the first patient, where here you can see there is some furring of the rotator cuff and the bursa. This is not the worst that I've seen, but that is a fairly typical appearance of patient with an impingement type of a problem. And you can see the scuffing marks even on the acromial side. Just run a short video on rotator cuff repair. So I've done the glenohumeral diagnostic part, and now I'm doing the cuff repair. I'm doing the bursectomy here. And it's quite important in a cuff repair that you do a very thorough bursectomy, as otherwise often this tissues will come in the way when you come to doing the repair. This video is on high speed to look for the timing, hence looks a bit strange. So once I've cleared that bursa and come to the acromial side to do a release of the CA ligament and then do an acromioplasty. I always do the acromioplasty at the beginning. Do an acromionectomy, remove a few millimeters at the front and then flatten it out, as this allows a bit more room. So where did it stop?
No, you can carry on from here.
Okay, so this is right at the beginning. Okay, so this is on a rotator cuff repair short video. This is initially doing a bursectomy. As you can see, you can just about see the tear in the background just there. And this all is the bursa, which one must take out, especially in a cuff repair situation, because otherwise it starts to close down when you start to do the repair, and it can become annoying. So I'm removing all the excess bursa. Once I've done that, I do the remove the CL or release the CL ligament, do an acromioplasty. I always do decompression or acromioplasty, removing a few millimeters of the anterolateral part of the acromion, and then flattening it out. So increases the space, and also by that time some fluid is gone into the subacromial space, opening it up, which provides easy access to do the repair. I also check for the lateral end of clavicle, and if it is enlarged, then I do a coplaning. Following this, I prepare the humeral head, just scour it with the same burr. And then you've got to assess the mobility of the tear. And you can see here that is, although it's a fairly big tear, the tendon is mobile. It's going to do a double row repair. So the first medial row anchor anteriorly, and the medial row anchor go in line just next to the articular surface. And it's a fairly vertical trajectory compared to the single row anchor where it used to be at a dead man angle. So once you put the first anchor, these days they come preloaded with a tape type material. They are high density polyethylene with high wear and thermolabine. And then you pass that through the tendon. Once it's done, take it away from a different portal and then put the second medial row anchor, which is posterior edge, as posteriorly as possible, and then do the same here. Pass this suture through the posterior edge of the cuff, posterior side. And then the device that I use is the speed bridge from Arthrex, and this has the tapes tied into a single wire which you split. And then I'll take one limb of the tape from the blue and the white, and then fix it to the lateral side of the humeral head. Here I start with the posterior anchor first because it's easier to go on the anterior side. The advantage of this system, it allows you to tension the suture, pull the suture in to give enough compression onto the tendon. You can see that tendon nicely pulled over. Now you can see there's a gap here at the posterior aspect of the repair. Now this device has a central holding suture, and I'm going to use that to see if I can close that gap. And then you hold it down with some knots. So although I prefer generally to do knotless repair for my cuff, but certain situations do require knots to be used. Once I've done that, then I'll go and do the anterior lateral anchor, and that's done. Now I can see there's still a gap at the posterior edge of the cuff, and I'm going to pass another mattress stitch and load it with a fifth anchor to cover that area. And you can see that tendon's pulled nicely into that slot. Once I've done that, I saw that there was still like a dog ear, and I'm using the central suture from the fifth anchor to tie and to close the dog ear and provide the repair. So that's a good repair for a fairly large tear. So in summary, I would advise that practice both beacher and lateral decupitous when you're training on your fellowship. I think it's important to understand your stack system and learn how to use the fluid management system. Familiarize yourself with instruments and use portals where you need them to complete the procedure effectively. Thank you very much. Thank you, Hitesh.
Thank you very much, Bijay, for that fantastic lecture. And something new that is step-by-step approach, and that's going to benefit a lot of people because of its unique nature. Just a few questions.
Yeah.
Do you have a stratification? For example, someone wants to start doing shoulder arthroscopy, because we have viewers from all over the world, and someone really wants to start off with the shoulder arthroscopy. So what do you recommend? What would be the one initial procedures like loose body removal or subacromial decompression? So do you have a stratification for the level of difficulty?
So yes, so certainly, well, you could start off with just doing a diagnostic or a washout scope where you don't need any instrumentation or anything. Or certainly the first one would be a decompression where all you need is a shaver and a burr. So even from your let's talk about if you're doing in India, from investment point of view, or from getting what you need to do and understanding it, that's pretty standard. And if you're used to doing knee arthroscopies, then you will have a set of shaver blades, and some radiofrequency probes. Even if you don't have radiofrequency probes, I know a lot of people don't use radiofrequency probe. Partly, it's expensive, and these days a lot of them have become single-use. The devices have become so clever that once you unplug it, the machine recognizes that it's been unplugged and it doesn't work the second time. But with the shaver blades, I know even in Europe, they reuse it, they re-sterilize it, and you can do the same for the burr as well. So yeah, decompression and that, followed by a cuff repair and stabilization is what I would go. Now, you can't say that there is something, yes, there are certain easy stabilization and difficult stabilization, but